Right now, inside millions of women, there is this like biological hostile takeover happening.
Absolutely. It really is.
Right. Because a temporary organ is basically hijacking the mother's metabolism. It's intentionally making her pre-diabetic and is,
Yeah.
completely rewriting her body's chemical rulebook,
Yeah.
all to feed this ravenous guest.
Yeah, that's exactly what's happening.
So welcome to the deep dive. Today we are looking at a really comprehensive medical textbook chapter by Susan Drummond. It's titled Endocrine and Metabolic Disorders in Pregnancy. And honestly, we're kind of stripping away that romanticized, soft-focused glow of creating life.
We really are. I mean, we're getting into the sheer biological mechanics of it. Our mission today is to map out exactly how a pregnant body radically rewires its metabolism to build a human.
Which is wild.
It is wild. And we're going to start by looking at the extreme baseline of what is considered normal, and then, analyze what actually happens when that highly fragile system gets pushed past its absolute limits.
Yeah, so whether you are planning a family or maybe supporting a partner, or honestly, if you're just someone fascinated by extreme human biology, you are really going to want to hear this.
Definitely.
Because the hidden chemical warfare and the intense biological negotiations happening inside the pregnant body every single second are, well, they're just mind-blowing.
Completely. And, to understand how things go wrong, we first have to understand the baseline. Like, let's talk about fuel.
Right, VA.
Because to build a human, you need a massive amount of energy, and the primary fuel for a developing fetus is glucose.
And getting that glucose to the fetus, that requires a highly specific biological mechanism, right?
Exactly. It's called carrier-mediated facilitated diffusion, which sounds complicated, but basically the glucose doesn't just passively seep through the placenta like water through a coffee filter.
It's an active process.
Right. There are specific protein carriers located on the placenta that actively grab glucose molecules from the mother's bloodstream, and they shuttle them across to the fetal side.
Wow.
So this means the fetal glucose levels are directly tied to the mother's levels. But here is the really critical safeguard. While glucose is shuttled across the placenta, insulin is completely blocked. It does not cross over.
Okay, let's unpack this. Because the way the mother's body manages this fuel supply, it completely changes depending on the trimester.
Yeah, it flips the script entirely.
Right. So think of the fetus as a VIP guest arriving at an exclusive restaurant. In that first trimester, the mother's body is just like prepping the dining room.
Right, setting the table.
Exactly. Her rising levels of estrogen and progesterone stimulate her pancreas to pump out way more insulin, and her own tissues become highly sensitive to it, actively pulling glucose out of her bloodstream and storing it away, which actually drops her fasting blood sugar by about 10%.
Yeah, her body's essentially stockpiling reserves early on.
Right.
But as we move into the second and third trimesters, well, the placenta fully forms and it just takes over the operation. The placenta starts pumping out this heavy cocktail of hormones.
All right, I've got them here. It's human chorionic somatomamotropin, cortisol, and prolactin.
A mouthful, I know. But these hormones are powerful insulin antagonists. They deliberately block the mother's insulin from doing its job in her own tissues.
So the VIP guest arrives, and the placenta essentially locks the mother's own cells out of the buffet.
Exactly.
It creates a state of significant insulin resistance, just ensuring that an abundant, constant supply of glucose stays circulating in her bloodstream, ready to be shuttled directly to the baby. But wait, if her own cells are resisting insulin, wouldn't her pancreas just burn itself out trying to overcompensate?
Oh, it definitely works overtime. I mean, to manage her own baseline functions while fighting the placenta's hormones, maternal insulin requirements routinely double, or they even quadruple, by 36 weeks of gestation.
Quadruple? That is insane.
It's a huge strain. If we connect this to the bigger picture, this beautifully orchestrated balancing act is essentially the body intentionally putting itself into a temporary pre-diabetic state.
Which is just a brutal evolutionary adaptation.
It really is. The mother's metabolic comfort is entirely sacrificed to guarantee fetal growth.
So if the placenta is actively inducing extreme insulin resistance just as a baseline, what happens if the mother's metabolic system is already compromised before she even gets pregnant?
Right, that introduces a whole new level of risk.
Yeah, let's look at pregestational diabetes, so women who enter pregnancy already managing type 1 or type 2 diabetes. The source material outlines some severe risks when you combine a compromised pancreas with those placental hormones. And they mentioned this system by Dr. Priscilla White from the 1940s.
Oh, yes, the White classification system.
Right. It categorizes pregnant women based on age of onset and organ damage, like classes B through T. And it specifically flags the risk of macrosomia, which, to be clear, is not just having a slightly chunky baby, right?
Not at all. Macrosomia is clinically defined as a baby weighing over 4,000 grams.
Wow, that's nearly 9 pounds.
Yeah, it's significant. And to understand why this happens, we have to go back to that placental barrier we talked about. The mother's high blood sugar is being shuttled across to the baby, but her insulin is blocked.
So the baby gets the sugar, but not the key to process it.
Exactly. So the fetal pancreas, which is perfectly healthy, detects all this excess sugar and starts secreting massive amounts of its own insulin just to handle the load.
And fetal insulin doesn't just process sugar, does it?
No, it acts as a primary growth hormone. The fetus uses all that extra glucose and insulin to produce excess stores of glycogen, protein, and fat. But, and this is crucial, the growth is asymmetrical.
What do you mean by asymmetrical?
Well, infants born to mothers with poorly controlled diabetes don't just get uniformly larger. They develop a disproportionate increase in their shoulder, trunk, and chest size.
Oh, gosh. Which explains the mechanical nightmares during birth.
Yeah, absolutely.
Because if the head delivers but the disproportionately large shoulders get stuck, you end up with shoulder dystocia.
Right, which is an obstetric emergency.
Yeah, leading to severe birth injuries, like a fractured clavicle or nerve damage in the baby's arm. But beyond the physical size of the baby, the mother faces this terrifying chemical risk called diabetic ketoacidosis, or DKA.
Right, DKA is basically a massive systemic failure.
It sounds scary.
It is. When a body cannot use glucose for energy because there isn't enough functional insulin, it panics. It starts rapidly burning fat stores, and this fat breakdown releases acidic byproducts called ketone bodies into the blood.
And that drops the blood's pH to lethal levels, right?
Exactly. In a typical non-pregnant adult, DKA usually triggers when blood glucose reaches around 300 to 350 milligrams per deciliter. But pregnancy completely alters the metabolic math.
Because her body is already primed to burn fat for her own energy while saving the glucose for the baby.
Precisely. The baseline metabolic stress is so high that in a pregnant woman, the threshold for DKA drops drastically. It can trigger when her blood glucose barely exceeds 200.
Barely over 200. That's such a tiny margin of error.
It is. And if the mother's blood turns acidic, it crosses the placenta. DKA carries up to a 10% risk of fetal death.
Wait, hold on. I'm looking at my notes here and I'm genuinely confused.
Okay, what is it?
We just established that insulin needs double or quadruple later in pregnancy to fight placental hormones. But the source material explicitly points out that women with well-controlled diabetes often have to reduce their insulin dose by 10 to 25% in the first trimester.
Right.
If the ultimate goal is feeding the baby, why would her insulin needs suddenly drop before the massive spike? Wouldn't she need more insulin from day one?
I know, it feels completely counterintuitive, but you have to look at the sequence of biological events. In that first trimester, the placenta hasn't taken over yet.
Okay.
So you have maternal tissues that are hypersensitive to insulin, aggressively storing glucose. You have a developing fetus rapidly siphoning off early energy. And crucially, you have the nausea and vomiting typical of early pregnancy.
Right, so she's not eating as much.
Exactly. She is likely consuming far fewer carbohydrates. Her circulating blood sugar is naturally much lower. If she took her standard pre-pregnancy dose of insulin under those conditions, she would just crash into severe hypoglycemia.
Wow. It really is a delicate chemical dance from week to week,
It really is.
which makes perfect sense as to why preconception counseling is highlighted as so critical in the text. I mean, if a woman's glucose is high during those early weeks, right when the fetal organs are literally forming from scratch, the excess sugar disrupts cellular development,
It does. It causes severe anomalies in the baby's cardiovascular and central nervous systems.
which is heartbreaking. You really need metabolic controls established before the embryo even implants.
Absolutely. But, managing an existing condition is just one part of the puzzle. We also have to look at what happens when the sheer stress of those placental hormones breaks a pancreas that was previously perfectly healthy.
Right. Gestational diabetes mellitus, or
Yep.
GDM. This is carbohydrate intolerance that develops mid-pregnancy. And the text says it complicates up to 18% of all pregnancies. But the way doctors even figure out if you have it is the subject of this massive medical debate.
Oh, it's a huge controversy. There are two completely different philosophies on diagnosis.
Let's get into that.
Sure. So on one side, the American College of Obstetricians and Gynecologists, or ACOG, they recommend a two-step method. Step 1 is a non-fasting 50-gram glucose screen.
Okay.
The logic here is to test how the body handles a sudden sugar dump in the middle of a normal day. If your blood sugar spikes too high after an hour, you move to step 2.
And step 2 is rough, right?
It is a grueling 3-hour test where you fast, drink a 100-gram glucose load, and get your blood drawn multiple times.
That sounds miserable. Then on the other side, you have the International Consensus Group, the IABPSG.
Right.
And they advocate for a one-step method. You just fast, you drink a 75-gram glucose load, and they check your blood at 1 and 2 hours. If even a single value is elevated, you are instantly diagnosed with GDM.
Exactly. And the metabolic logic of the one-step test is that fasting creates a highly controlled baseline. It detects much milder forms of carbohydrate intolerance than the two-step method.
So what does this all mean? The material shows the one-step method catches so many more cases that it would literally double the diagnosis rate of GDM.
Double it. Yes.
Yet 95% of U.S. obstetricians still use the older two-step method. And the text suggests it's because doubling the diagnosis rate would massively increase healthcare costs.
Yeah, that's a big factor.
I mean, we're talking more maternal fetal medicine visits, more fetal monitoring, more insulin prescriptions. If you're listening to this, you might be wondering, are we actively choosing to underdiagnose a pregnancy complication just to save the healthcare system money?
Well, this raises an important question about the balance of medicalization versus actual clinical benefit.
Fair point.
Because the counter-argument to the one-step method is that diagnosing twice as many women with mild intolerance doesn't necessarily lead to a clinically significant decrease in bad outcomes, like macrosomia or birth injuries.
Oh, I see.
Yeah, you run the risk of aggressively medicalizing a pregnancy. That causes immense anxiety and pushes unnecessary interventions on a woman who likely would have delivered a perfectly healthy baby anyway.
That makes a lot of sense. But the stakes of that diagnosis, they don't just end in the delivery room.
Not at all.
The treatment starts with a strict diet, like precisely 33 to 40% carbohydrates, careful counting, moderate exercise. And then it moves to medications like metformin or insulin if thresholds aren't met. But while we focus so much on the immediate health of the baby, the most staggering detail to me is what GDM means for the mother's future.
It's a huge red flag. Because once the placenta is delivered and those antagonist hormones disappear, GDM usually resolves almost immediately.
Right.
But the damage to the pancreas is a warning sign. Up to 70% of women who develop GDM will develop type 2 diabetes within 10 to 20 years.
70%. That is an absolutely wild statistic.
It is. Pregnancy acts as a crystal ball. It is the ultimate stress test of your metabolic system, revealing pancreatic weaknesses that might not have otherwise shown up for decades.
Wow. So manipulating hormones that aggressively, it doesn't just stay isolated to the pancreas. The overflow of those chemical changes wreaks absolute havoc on the digestive tract, too.
Oh, definitely.
It essentially breaks the body's internal alarms.
Yeah, we see this with nausea and vomiting of pregnancy, or NVP, which affects 50 to 80% of women.
And while it is miserable, biologically, it serves a purpose.
It does. It's an evolutionary adaptation designed to protect the fetus from potentially harmful or spoiled foods during the most vulnerable stages of early development.
Right.
In fact, pregnancies with standard NVP actually show more favorable statistical outcomes.
Here's where it gets really interesting. If morning sickness is an evolutionary car alarm designed to scare off bad food, hyperemesis gravidarum, or HG, is like a car alarm that completely malfunctions.
Yes, perfect analogy.
It just blares nonstop until it entirely drains the car's battery.
Exactly. HG affects a small percentage of pregnancies, up to 3%. But the severity makes it the second most common reason for hospitalization during pregnancy.
That's intense.
The mother's body simply refuses to accept nourishment.
And the physical mechanics of what happens during HG are terrifying. Because the mother can't keep anything down, she experiences severe weight loss, profound dehydration, and severe electrolyte imbalances.
It's brutal.
The constant violent retching can even cause an esophageal rupture. But the craziest complication detailed in the text is Wernicke encephalopathy.
Yeah, Wernicke encephalopathy is literal brain damage. It's caused by a severe deficiency in vitamin B1, or thiamine.
Brain damage just from vomiting.
Yes, because the brain requires thiamine to process glucose into energy. When a mother is vomiting constantly for weeks, her thiamine reserves deplete. her brain cells literally begin to starve and break down, leading to confusion, vision changes, and a complete loss of muscle coordination.
This is where medical intervention has to step in and completely override that broken evolutionary mechanism.
They really do. It's an emergency.
They start with IV fluids to stop the dehydration. Then they move to medications like Daclogis, which is a very specific combination of pyridoxine, which is vitamin B6, and doxylamine, an antihistamine.
Right. And the mechanism there is fascinating. The B6 helps process amino acids and lipids to settle the stomach, while the antihistamine acts on the brain's vomiting center to dampen those nausea signals.
And if that fails,
If that fails, they have to escalate to dopamine antagonists or even corticosteroids. And they're constantly carefully weighing the risk of the drug against the stark reality of maternal starvation.
and the diet adjustments they prescribe aren't just like telling her to eat healthier.
No, not all.
They are highly specific, desperate survival tactics. Separating liquids from solids so the stomach never stretches too much, the salty and sweet approach, which is eating a protein immediately after a simple sugar, and utilizing ginger to naturally accelerate stomach emptying.
It's a brutal psychological and physical test of endurance for the mother, trying to find any calorie that will stick while constantly worrying about the life growing inside her.
And the hormonal flood doesn't stop at the gut either. It pushes the thyroid and the liver enzymes to the absolute edge, requiring like pharmaceutical gymnastics to keep both patients safe, both mother and baby.
Yeah, the thyroid is a great example of this.
Let's get into the thyroid, because the mechanics here are a pharmaceutical tightrope. During a normal pregnancy, the thyroid naturally increases production of its hormones by 50%.
Right.
But in hyperthyroidism, which is usually caused by an autoimmune condition called Graves' disease, the thyroid goes into a dangerous overdrive. The mother's metabolism runs so fast, she actually risks heart failure.
Which means she needs medication immediately to block the thyroid from overproducing hormones. The two main drugs are PTU, which stands for propylfuracil, and MMI, methimazole.
Okay.
They both work by preventing the thyroid gland from converting iodine into active hormones, but they interact with the placenta very differently.
Right. During the first trimester, the doctor absolutely has to prescribe PTU, because if they use MMI, it crosses the placenta in a way that disrupts early fetal tissue formation.
Yeah, the side effects are severe.
It causes birth defects like facial anomalies and esophageal atresia, where the baby's feeding tube doesn't even connect to the stomach, to use PTU. But after the first trimester, the doctor has to immediately pull the mother off PTU and switch her to MMI. Why is that?
Because while PTU is safer for the fetus early on, prolonged use carries a severe risk of causing maternal liver failure.
Oh, wow.
Yeah, it can destroy the mother's liver so thoroughly she might literally require a transplant. But by the second trimester, the baby's organs are fully formed, making MMI safe for the fetus again.
Okay.
So the medical team swaps the drugs to protect the baby first, and then swaps back to protect the mother.
It is a terrifying biological negotiation. And on the flip side, you have hypothyroidism, where the thyroid isn't making enough hormone. The treatment is a synthetic hormone called levothyroxine, but here's the catch. Pregnant women are universally prescribed prenatal vitamins loaded with iron to build fetal blood supply.
Right, everyone knows about prenatals.
Yeah. But if the mother swallows her levothyroxine and her iron supplement at the same time, the iron physically binds to the thyroid medication in her gut, rendering it completely unabsorbable. She will literally flush the medication right out of her system.
So she has to space them out by at least 4 hours. Otherwise, she drops into a hypothyroid state, which deprives the fetal brain of essential developmental hormones and dramatically increases the risk of miscarriage.
It just highlights how every single chemical input in a pregnant body interacts with everything else.
It's all connected.
Which brings us to the most extreme example of maternal-fetal metabolic connection in the entire chapter. Maternal phenylalanine hydroxylase deficiency, or PAH deficiency.
Yeah, you might know this by its older name, PKU. It is a genetic disorder where the mother's liver lacks the specific enzyme needed to break down an amino acid called phenylalanine.
And phenylalanine is in practically everything.
Everything.
It is a fundamental building block of all protein, meat, dairy, nuts, even artificial sweeteners.
Right. And in a non-pregnant adult with PAH, high levels of this amino acid can cause cognitive issues over time. But in pregnancy, the placenta actively concentrates phenylalanine and pumps it straight into the fetal bloodstream.
That sounds dangerous.
It is. If the mother's blood levels rise above just 6 milligrams per deciliter, it becomes highly toxic to the developing fetal cerebral cortex. It physically impairs brain growth, causing microcephaly, irreversible intellectual disability, and severe congenital heart defects.
It absolutely blows my mind that a mother with PAH can cause permanent, severe brain damage to her baby just by eating like a normal piece of chicken. How is that even managed?
Through absolute, unforgiving dietary compliance. The mother has to adopt a strictly calculated, heavily restricted synthetic diet months before conception.
Wow, months before.
Yeah. She has to ensure her blood levels of phenylalanine are perfectly suppressed before the embryo even implants. And then she has to maintain that flawless chemical balance every single day of the pregnancy.
Which perfectly encapsulates the entire journey we've mapped out today. From the intentional insulin resistance designed to feed the VIP guest, to the broken evolutionary car alarm of HG, to the pharmaceutical drug swapping of thyroid management.
It's a massive undertaking.
It really is. Understanding the profound mechanics of these extreme metabolic shifts completely strips away that soft focus glow we talked about at the start. It replaces it with this intimidating, awe-inspiring respect for the chemical warfare a female body negotiates just to create life.
Absolutely. And what's fascinating here is that for all the chaos, disruption, and near-system failures we've discussed, the source material leaves us with an incredible detail about the generational ripple effect of what happens after the birth.
Oh, yeah.
Specifically regarding breastfeeding.
Oh, this part of the text is incredible. Let's get into it.
We discussed how gestational diabetes acts as a crystal ball, predicting a 70% chance of the mother developing type 2 diabetes. And it also predisposes the baby to future metabolic issues.
Right.
But the text reveals that if a mother who endured diabetes during pregnancy exclusively breastfeeds her infant for at least 6 months, it significantly decreases that child's risk of developing childhood obesity and non-insulin-dependent diabetes later in life.
That is just amazing. So after enduring 9 months of being hijacked by a biological hostile takeover, surviving insulin resistance, and battling placental hormones, the mother's body produces a milk that literally acts as a metabolic shield.
Yes.
It physically rewrites the medical future of the next generation.
It's a remarkable restorative closing act to an extraordinarily taxing biological process.
It really is. You start out thinking pregnancy is a gentle miracle, and then you realize it is a massive, systemic, endocrine disruption. But in the end, it creates a shield.
Beautifully put.
Well, that's all for today's deep dive. We'll catch you next time.